Welcome, everyone, to a new year of the CNS Journal Club podcast, and thank you so much for joining us today. My name is Kimberly Hoang from the Department of Neurosurgery at Emory University in Atlanta, Georgia. My practice focuses on tumors, and it is my honor today to moderate the discussion of a very interesting article in the newest edition of the Red Journal, hot off the press, entitled Functional Reorganization of the Mesial Frontal Premotor Cortex in Patients with Supplementary Motor Area Seizures. The SMA is always a relatively hot topic in neurosurgery, and today we welcome Dr. Hoang, the lead author, Dr. Van Gompel, our guest expert, and Dr. Domino, our resident co-host for the discussion. Dr. Hoang, could you tell us a little bit more about yourself?
Thank you. Good evening, everyone. I'm delighted to be here to talk about our work. So I'm a neurosurgeon at Dartmouth-Hitchcock, and I do epilepsy surgery as part of my subspecialty practice. And this paper is a really interesting accumulation of really decades of data on interhemispheric mapping of these epilepsy patients. And we got very interested in this topic because there is so little known about the SMA in human subjects. So that was really what motivated our study. Great.
Dr. Van Gompel, would you like to introduce yourself?
Hey, Jamie Van Gompel, Mayo Clinic in Rochester. Skull base and epilepsy surgeon, and very curious to talk with Dr. Hoang about this today. So I really appreciate the opportunity that CNS has presented for us tonight.
Wonderful, thank you. And Dr. Domino, would you finish off by introducing yourself?
Yeah, I'm Joe Domino. I'm a PGY7 at the University of Kansas. I'll be doing a neuro-oncology fellowship at Moffitt next year, and I'm the resident planner and co-host for this. So, very excited to see what the discussion holds.
Great, thank you. Dr. Hoang, you mentioned the origins of the data. For our audience, could you give a brief review of the article, maybe some of the key findings and the major conclusions, please?
Sure. So this is a retrospective review of 25 patients at our center that were implanted over a period of 25 years, actually. And in each of these patients, they were studied for potential seizure onset zone in the SMA and frontal lobes. And what we did was we sampled everyone who had detailed mapping of the interhemispheric grid. We use a very large double-sided grid in many of these patients to investigate the site of their seizure onset. And then we divided the patients into two groups, those who had seizure onset within the SMA, and that was defined as someone who actually got treatment based on that finding, so a resection or neurostimulation in that region, versus the patients who had seizure onset in areas outside of the SMA. And so what this gave us was kind of a nice control group of sort of similarly implanted patients, because we didn't know sort of a priori where their seizure onset zone was going to be, that served as basically normal mapping controls. And then we pooled data from these two cohorts and then compared basically the somatotopy of the SMA based on evoked responses during cortical mapping. And what we ultimately discovered was that patients who have seizure onset within the SMA tended to have altered localization of trunk and head responses. And this was done multiple comparisons just to ensure, since we're working with fairly sparse data, that this was a real result and not a consequence of sampling error or patient selection.
Great, yeah, makes good sense. I guess we'll start off with questions from Dr. Van Gompel, our expert guest.
Well, I want to first make a comment prior to questions. So I know we have some prepared questions, but my first neurosurgical publication was in the Red Journal about subdural grid implantations a long time ago. I think it was 2000 and I want to say 8. And the Dr. Hoang's group here is, I don't think that people understand how difficult of a group this is now because we do so much SEG monitoring now. So to have a unique group of 25 patients with interhemispheric grids as large as these are, it's very uncommon, and it's a really unique data set, as she pointed out. So I wanted to highlight that because I think she just, I think she's not giving, Dartmouth enough credit for how difficult this is, or Dr. Roberts and Dr. Hoang. Honestly, it is an extremely unique data set, and it's exciting to see what they did with this because, to put these large 3x8 grids interhemispherically, and if anybody has played with these before, what these are is they're thicker than normal plastic and they're double-sided typically. And they're not pliable like the old subdural grids, or if anybody here does intraoperative electrocorticography, they're not as pliable as those are. And to get these inserted, with the amount of veins that you have to, and to do with minimal complications as they have. Now, they didn't cover complications in this, but presumptively the patients were able to get mapped, so they must have done pretty well for a fair amount of time. So it's an impressive group of data. And I think that, again, just knowing what's happening with epilepsy surgery and knowing that people are using mostly SEEG to map this type of information, I don't think we're going to have another population like this again. But I'm going to go a little bit out of order. I'm going to ask a question because of the 25-year period of time that was collected. So just to ask Dr. Hoang, how can we be reassured that the data collection was uniform across this group over 25 years with groups and physicians coming and going? Because I think that is the essence of how you've done the data analysis. So I'd like to hear a little bit about that.
Yeah, absolutely. I think, as patient data is, pretty fragile, and it is definitely liable to get purged, like just as information systems turnover and as physicians turnover. One thing that's been really nice is that during that period, we did have one primary surgeon doing all of the implants. So that was Dave Roberts and his expertise. And so, technically the surgeries and the approaches were very similar between the two groups, even though it was over a period of years. And the other thing is that, we are really committed to studying these patients, and we have this very large database that we've accumulated, and it's got to the point at one point when I was reviewing these patients that I was actually looking at VHS tapes. Like, we really did do a lot, to make sure that the data had good integrity, and we were actually looking at real seizures and real mapping events. So yeah, we worked hard at that, because you're right, it's an absolute problem, especially in a retrospective review.
Dr. Hoang, were the VHS tapes of the operation themselves, or were they the SMA mapping? Could you clarify?
Yeah, the mapping and then the clipped seizures with the EEG. Yeah.
So I think that's really important, because it's hard to ensure data integrity over 25 years. And it sounds like, and knowing Dr. Roberts very well, I know he's not operating any longer, that, I wouldn't expect anything else, as well as Dr. Jobst, who's the corresponding author on this paper, as I recall. And so she's quite an amazing person, and I would expect none less from her, by the way. So
yeah, I agree completely.
So the primary question I had, so the way I understand this paper is, there's 25 patients that were accumulated. 13, I believe, had SMA onset seizures. 12 did not. And of the 12 that did not, they ultimately, 3 of them didn't have a localized seizure. So they're a little bit of a varied group. But the idea was that SMA mapping was done, in interhemispheric SMA mapping was done. And in that group, they're divided into 2 different groups, and you made centroids based on, arm, trunk, leg, that kind of things. And you did a control of vision. The data, and I guess my question is, with that low number, although I don't want to say low number, because I want to also emphasize what I just said, that this is a huge number, that we're not going to see this again, at least without SEEG data. So surface EEG is different, obviously, than SEEG data.
Yeah.
How do we know if you didn't divide them in randomly groups? So for instance, there's cortical dysplasia groups. So you have 5 cortical dysplasia groups in the seizure onset in SMA, and 4 in the non-SMA onset group. How come, if we would have used those as separate groups, how much variance would we have seen in the centroids that you created?
Yeah, that's an excellent question. And I think when we first did the analysis, just taking all electrodes into consideration, we saw this discrepancy between the trunk mapping and head mapping with sort of the entire data set. And honestly, I was pretty skeptical, and I thought, well, is this real? Because yeah, you're right. Could be, small variations within an individual could, sway the mapping data. And we all know how, mapping is not quite as robust as other sort of more objective measures sometimes. So we did two things to try and really ensure that these results were real, that these differences were not artifacts. So one thing we did was to do something called matching with replacement. So when we looked at basically the geometric distribution of the two groups, we found that in the SMA group, the electrodes, even though they had very good coverage of the inner hemispheric areas, as a group, they tended to be shifted slightly more anterior compared to the non-SMA. And that's probably because we had a hypothesis about a premotor onset, and those electrodes maybe tended to be more anterior. So what we did is, in fact, we resampled the electrodes so that they had exactly the same anatomic and geometric distributions. So we took all the responses in the SMA, and then in the non-SMA set, we selected like the closest matched electrode with the response, and did a subgroup analysis with just those electrodes, which in theory would eliminate all of the sampling bias due to electrode distribution. And within that smaller set of electrodes, we found that the differences were still real. And then the other thing we did is we did sort of a sensitivity analysis posing your exact question. So, if the patient had a lesion on the MRI, or if they had even pre-existing motor deficits, could they have mapped before, we even did the surgery? Could they have had sort of intrinsic changes? And what we did is we actually removed the electrodes that were from or sampled from those patients specifically, and reran our analysis each of those times. And then in both those instances, the trunk and head area still remained, statistically different between the two groups. It's really difficult in some sense to know 100% for sure, because you can't, in a retrospective review, you can't ensure all the electrodes were placed exactly the same way in every patient covering exactly the same cortical regions. We had to sort of think about ways of sort of manufacturing that from the existing data that we had.
I will say, if I did not review this article, however, if I would have reviewed this article, I would have asked you to do a subset analysis presented in the paper, because you lumped right and left together. And you also lumped in your focal cortical dysplasias, which we know causes reorganization. I would have asked for a specific subset centroid analysis for those two. Did you happen to do that separate from this analysis and look at it? Did it alter the outcomes, or did it overly influence, obviously? Because what I'm thinking is, in a dominant hemisphere, it's difficult because the SMA is so complicated to distinguish what it does language-wise with what it does motor-wise. And I have a feeling, just looking at this data, that it influences, and I can't shake it without seeing the data in the paper, right?
Yes, so that's a great point. So we did combine sides, dominant, non-dominant sides, in the analysis just for power. And that's because when you're looking at, 51 versus 72 points, even any filtering of that, dramatically reduces the power of your analysis. So, but I think you're right. I think if we had more patients, we would absolutely do that subgroup analysis, because that would be very interesting to see, how much of those speech responses accounted for upper, facial or head movements. With respect to your focal cortical dysplasia question, we did run our, general linearized model with the focal cortical dysplasias removed, but we didn't do the opposite analysis. We only did it with the focal cortical dysplasia patients. And that's, again, a question of power, just getting, data points from 5 patients to compare. We didn't feel like there was enough data to make a strong conclusion.
See, I would have made a counter argument to that if you would have given me that as a reviewer, that a power analysis is irrelevant here, right? Because you have such a small group of patients already that it would not matter. And you want to see if these groups are overly influencing what those centroids look like. And I think I would have been pretty bullish about asking for those things because I'm still very curious. And I think, you know, if you still have the data, it'd be actually worth a separate paper to look at how those impacted this.
All right. Yeah. That's a great suggestion. We'll see what we get. Yeah.
And I have other questions, but I'll hang on to them for a little while. Maybe we can move on to a different reviewer.
No, great questions. So from Dr. Domino and myself, who are a little bit more tumor focused people, SMA is certainly a continuous challenge for us as well, just like for our functional colleagues, both with counseling our patients and guiding our resections from an oncologic perspective, of course. Obviously, we don't place those interhemispheric grids that Dr. Van Gompel was talking about during our oncologic resections. Maybe we should. So how do you think your findings about reorganization and such from your article might help oncology surgery as well, particularly, I think, with low-grade disease that might allow for more of this reorganization that you bring up, similar to what you might see potentially in epilepsy?
Yeah, that's a great question. I think I was thinking about this, and I think you're right there. You know, it'd be nice, and it would kind of be a fascinating separate study to map these in the tumor patients. Although I know SMA stimulation is difficult because of the high currents needed and the risk of intraoperative seizure. But it'd be curious to see whether like a reorganization prior to your tumor resection would predict good outcome from SMA or good recovery. I think what I would take away from this is that there is a high degree of plasticity in this area. And that kind of opens the door to sort of think about, is there a way, if you're going to anticipate you're having a resection of this area, is there a way to leverage that plasticity maybe before surgery, and think about, if there's a way to either through therapy or maybe more work on sort of the mechanism of the plasticity for encouraging the brain in this region to be more plastic before you anticipate a resection of a tumor. But yeah, that's a great question. I think the ultimate goal would be to be able to do some sort of predictive modeling for outcomes after a resection, both in the functional and the oncologic world. But you're also, I think you guys are, as tumor surgeons, also, your goals of surgery are really going to be slightly different. It'll be an interesting discussion to think about modifying the extent of resection based on function.
Can I couple on to Dr. Hoang's question, because it is interesting to think of how a tumor surgeon addresses the SMA compared to what you did here, right?
Mm-hmm.
So a tumor surgeon isn't going to go interhemispheric typically, although we do motor mapping interhemispheric, not uncommonly,
Mm-hmm.
right? But most of what the mapping is going to be exposed brain or the lateral cortex, which is a fair amount of the SMA. And what I was surprised to find in your data was when you just mapped interhemispherically, you found representation of all of motor functions, and you reported that. You'd think that independently you'd have some absence, which would be, superficial, right? And I think you see that even, so when we do mapping with grids that are on the cortex, we do see similar representations here. So how do you tie those two together with what Dr. Hoang was asking?
So your question is,
you're only mapping the interhemispheric portion of the SMA, and you're neglecting a fair amount of it, right? But you're finding all of the function there on your interhemispheric mapping. How do you explain that?
So it's not, so we are finding all the functions, but it's not that they're all present for every single patient. So the representative somatotopy that we're modeling here is a composite between different patients. So it's true that within certain individual patients, you may not see every single function represented. And we do see that. But when you take the group as a whole, we do see arm, leg, trunk, and head responses across the board in the interhemispheric region.
Yeah, I thought it was really interesting that you brought up the idea of, rehab potentially, obviously a very hot topic, navigated, or a TMS potentially as a way to sort of rehab patients beforehand. So I think in generally recovery after surgery in the SMA region is quite heterogeneous. I know it's difficult for me to sometimes counsel my patients, aside from the fact you're likely to have SMA, what it might look like, and everyone's so different. Do you think your work might be able to help us better counsel our patients about SMA and recovery, since it is so different across all of our patients we treat, depending?
Yeah, I mean, one of the things that I've personally taken from reviewing all the patients, and looking at their data is that there is inherent variability, and maybe that's sampling. Maybe it's because we don't have like perfect coverage all the time in every patient, and if we did, that would be the perfect study, right? If I could do this, now moving forward and have all the benefits of having done the retrospective look. But I think one thing I would say about recovery, one thing I would love to do is if we could go ahead, prospectively follow these patients, it'd be great to see if an individual sort of, if we could come up with a degree or some sort of quantitative measurement of how greatly they've rehabbed, or maybe some idea of how intrinsically plastic this area of their specific brain is at the individual level. It'd be nice to know, prospectively looking at their functional outcomes, what happens after the resection. And we just didn't have in this data set enough to do that. But this is a question that might be answered in a collaborative fashion across different institutions potentially, if we have enough patients, or we could start to build really a big atlas of mapped responses, and then follow them and look at their outcomes. I think it's reasonable to hypothesize that if you have a greater degree of remapping prior to your resection, whether that's for epilepsy or for surgery or for tumors, maybe you do better. Like maybe you do have better recovery or faster recovery.
Yeah, I think along those lines, obviously responsive neurostimulation is more at the fore, and we're doing more of that. So I don't know if you've have those patients, or any sort of kind of sense whether if we get that closed loop feedback, that our neurologists are looking at a lot, does it change? Are they seeing changes? And obviously we have to, you're not having the ability to map it as well, but do you see kinds of changes in the data that we're getting back from these patients? And I guess especially if you're thinking about SMA region.
Yeah, so we have a fairly small experience with responsive neurostimulation in the SMA. I don't know, Dr. Van Gompel, whether you have more to say about this, but in the couple of patients, I think there was just 3 that we did an SMA targeted stimulation with the RNS. We haven't really seen a big change in motor function, or really even in the efficacy of the stimulation. So I guess it's a very small number, so I can't say anything conclusively, but right now I don't think that there is a change related to stimulation, but I don't know that for sure.
Dr. Hoang, I think it's a tough question. So what Dr. Domino was saying, what is truly function? And you don't address that in this paper, right? So you don't look at the SMA resection cohort, because a lot of them went on to surgery. And it shows how difficult of a patient population this is. Not a lot were seizure free after, but there was a lot that improved.
Correct.
But the question, and this gets into Dr. Hoang's question is, if you map the centroid and you resect it, what happens, right? And we don't know that. And I think again, that's what's so fascinating about research. And this is such a unique cohort that would be another. So we said another paper for looking at different cohorts, but that would be another really interesting thing to know, like that you mapped this pre-op, you resected it, because there are a lot of surgeons that may put responsive neurostimulation or something. We do cortical subthreshold stimulation, but however it is that you do it, they may say that's function. And, and Dr. Hoang says, well, we cut that out all the time. They spent half the patients don't have any problems, and then the other half go to rehab and they're great 2 months later, right? So I don't know. I think it'd be really cool to see in that population and those that were resected, what ended up happening with your mapping, if that was removed, and what happened to those patients with that function?
Yeah, absolutely. Yeah, we should look at it.
Lots of future papers out of this, Dr. Hoang.
I'm gonna take notes. I'm like writing this all down.
See, my poor residents, every time they have a project with me, it's a never-ending project.
Well, wonderful. Any further questions from our group?
No, thank you so much. This is great.
Great. Oh, go
I
ahead.
do want to just congratulate Dr. Hoang. I think it's a really good paper, and it's it shows the quality of work that goes into the Red Journal, and there's a lot of that can be done with this type of information, but it's such a unique patient population. I wouldn't let go of it because I don't think people are going to do this again. It's such a hard surgery to do, and we will do this with SEEG, but it's not the same.
Mhm.
It's not the same as this is a very unique population. I congratulate you and Barbara and obviously David and the whole group at Dartmouth for such phenomenal work.
Thank you. Appreciate that, and appreciate the encouragement. Yeah, this has been a very interesting experience, just reviewing all of this data, and it's hard data to work with in some ways, but it's very rich, as you point out. So certainly there's more to learn.
Wonderful. Well, I think we are nearing the end of our time. I would like to thank, of course, our excellent panel and guests for their stimulating discussion, and it certainly has given me a lot to think about. Thanks to our loyal listeners for continuing to support the podcast. We hope you learned something new today in your practice. And remember, you can obtain 1.5 CME, which is complimentary to all CNS members. The link to the CME activity is available in the online education catalog at cns.org. We'll see you all next month.